Hi, I'm Liz Thurston with Johnston Health. Thank you for joining us today for Johnston Health Talk. Today we have with us Dr. Cary Bizzell, who is a radiologist at Johnston Health. We're going to talk today about breast cancer awareness and the tools used to detect breast cancer. As we all know, October is Breast Cancer Awareness Month. Thank you for joining us, Dr. Bizzell.
Thanks for having me.
So I think it's so important, and I love this time of year to be able to educate people and tell everybody about breast cancer awareness and all the new things coming forward with detecting breast cancer. So tell us, as a radiologist, I'm sure obviously you're reading a lot of breast examinations.
Yes, absolutely. And screening mammography is such an important tool to detect breast cancer. In fact, it's the only screening tool that's been shown to reduce mortality from breast cancer, and it's been shown to decrease the death rate from breast cancer by 30%.
So let's talk a little bit about the facts of breast cancer. Women, it's one of the biggest diagnoses for women to develop breast cancer, and so what are some of those statistics that you're seeing?
Well, so the reason that we make such a big deal about screening for breast cancer is that it is such a common disease. 1 in 8 women will get breast cancer in their lifetime. That's such a high rate that it's so critical that we pick it up at an early stage when it's still treatable. Some other statistics that are out there, every year there are 220,000 cases of breast cancer that are diagnosed in the United States alone. It's also very common worldwide as well. And another statistic is that 40,000 women who have breast cancer will die every year.
Wow. And that's such a large number, it really is. And I have here that cancer is the second leading cause of death in Johnston County, actually, where Johnston Health is located. And that there'll be 106 or 166 of new cases detected each year.
Absolutely, and that's why it's so critical that we pick up these women at an early stage before it gets to a level where it's spread to other parts of the body. At that point, sometimes the treatment options are more limited and much more serious and can be much more extensive and costly.
And we keep saying early detection, early detection. And some of the ways that we can do that is not only getting our yearly exam, which we should do with our primary care doctor or our OBGYN, but also self-examinations, correct?
Absolutely. And so the self-breast exam, a woman should do that every month. And it's important that every woman be very comfortable and understand what your breast is like. Because every woman has different breasts. Some women have lumpy, bumpy breasts. Other women don't have as lumpy breasts and they're more fatty and smooth. So everyone is different, and it's very important that the woman understand and know what their own breast feels like.
It's funny that you say that because one of my questions to a doctor friend that I had was, well, you know, what are you looking for? How do I know what a lump is, or that it could be a spot that I should be concerned about? And he said that exactly. You need to know what your normal is. You need to know that this is what you normally look like, and every month by checking you can see if there's any changes. So you're looking for a change.
Absolutely, and the most important thing is that you keep track for those changes, and it depends on the time of the month with a woman that is still undergoing her menstrual period, so it's always important to try and do that self-breast exam around the same time of the month, so that way you have a standard that you're going for. It's kind of similar to how when you get weighed on a different scale, you can have different numbers for your weight, and so you always want to get weighed on the same scale.
Exactly.
It's the same sort of theory there.
Yes, and we always want to weigh the same or less.
Absolutely.
So yeah, and then also doing those exams, I didn't realize this in talking with Sean Legan about that examination, that your breast actually goes up into your armpit too. So it's not just the fatty area, it's up in your armpit that you should check as well, correct?
Absolutely. So the breast exam should be done not only of the breast itself, but it should start right in the midline, right at the breastbone, at the sternum, and you should go in a circular pattern around the breast and all the way out to the armpit, because there is breast tissue that can go all the way to the armpit, and there are also lymph nodes that live in the armpit, and that's where breast cancer can spread, and sometimes that's where cancer is picked up the first time. It's actually picked up with a lump in the armpit rather than in the breast itself. Sometimes the breast cancer in the breast is so small that it can't be felt, and that's why we do mammograms. And
Right.
even on mammography, sometimes the breast cancer can be so small that it really doesn't show up until it gets into the armpit.
And that's a good lead way to talk about mammography. I actually had a friend who had a mammography, her annual done, and it was not detected, and she went for her physical exam, and her doctor actually found the lump in her breast. And so right now we use 2D mammography. So let's talk about 2D versus 3D, which we're hoping to go with.
Sure, okay. So first, I guess we can talk about just regular 2D mammography and what that means for those women who have not had it done before. I would absolutely recommend that you get a mammogram done for a screening if you've never had it done before. I highly recommend that you come in for a baseline mammogram to at least get a baseline to see what not only to find out what your breasts look like on mammogram, but also to find out what sort of density that your breasts have. It's been shown that about 45 to 50% of women have what's called dense breasts. And having dense breasts, that in and of itself is an increased risk for breast cancer.
Okay.
Without any other risks, that breast cancer can happen in women who have dense breasts. It's been shown that that's more common. So what that does, it also makes it more difficult to pick up a small breast cancer on a regular screening mammogram, our 2D screening mammogram that we've been doing. And what that is when you go in to get a mammogram done, your breast gets compressed in two different ways. It gets compressed from the top down and from the side, and each breast gets done that. So you get 4 pictures taken, 2 of each breast. And so that is what our traditional screening mammogram has been done. What a 3D mammogram does, it actually takes it a step forward. Your breast is still in compression, but what it does, the machine will go along a curve around the breast, and it will actually take a couple of thin slices through the breast. Instead of looking at it in one picture, that dense tissue that can get overlapped, and a breast cancer can easily be missed when you have dense tissue overlapping on just a routine 2D screening mammogram. What a 3D screening mammogram does is it takes little slices through the breast, and it helps us to pick small abnormalities out much better than we would otherwise if we just do a regular 2D screening mammogram.
Okay. And you hear that a lot, dense breasts, and this being a better option for all women, but also more so for women with dense breasts.
Absolutely, and like I said, that is a risk factor for breast cancer just in and of itself. Of course, we could talk about some of the other risk factors for breast cancer.
Yeah.
The 2 most common risk factors, unfortunately, it's what every woman has. It's being a woman.
Right.
So that's actually a risk factor, of course. Men do get breast cancer, but a much less common. It's about 1 to 2% of all breast cancers per year are from men. Another risk factor is age. And so, again, 1 in 8 women are going to get breast cancer. So as the risk goes up every year as women get older. So those being a woman and age are 2 risk factors, which at a certain age, every woman has those risks. And some other risk factors, we have to take into consideration what's happened with a family history. If a woman has multiple family members that have had breast cancer in the past, then that may put them at an increased risk, particularly if they're first-degree relatives, a mother, sister. That can be an increased risk. There's some other risks as well. A little more uncommon risk factor is women who have had radiation therapy to their chest as a child for lymphoma or other cancers. High dose radiation does cause an increased risk for breast cancer in the future. So we consider anyone who has a lifetime risk of 20% to be high risk. And so that's the number that we use, and anything below that is considered average risk for the population.
So as we age, you said being a risk factor, are you seeing it, you see it more prominently in women age 50 to 85, I think, is that what I read? Is that correct?
Right, yeah, absolutely. Yeah, it's more commonly diagnosed in women 50 to 70 in that age range. But keep in mind that there is still a significant number of women in their 40s that do get breast cancer. And so we also don't want to miss those women. And, and again, the most important thing to also consider is the fact that about 70 to 80% of all women who get breast cancer are not high risk.
Okay. And I was going to ask you that because I did hear something that family history does play a large role in your risk, but not a large percentage of those cases that are diagnosed are because of family history, that you're finding it in women that are, just aging women, in that bracket.
Just average risk, and that's why 70 to 80% of women are they're going to be the ones that get breast cancer. It doesn't run in their family. They haven't been on hormone replacement therapy. There's been no other risk. They're what's considered an average risk, and that unfortunately is still what is most common. That is why screening for breast cancer is so important, and we have to include all women and not just screen our high-risk patients.
Mm-hmm. And is that because of hormonal change, that as we age, just the changes in our body that's maybe making us at a higher risk?
Yeah, it's considered one of the risks is the lifetime accumulation of hormones. So the breast gets stimulated by hormones, and so when the women have menstrual periods every month, and so the hormones change and stimulate. Not only do they stimulate the ovaries to have the menstrual periods, but it's also stimulating the breast. And so the breast gets that stimulation of hormones, and over a long-term period of time, that's considered to be what can cause breast cancer. And so that's why we see it in older women, because they've had more years of having that hormonal stimulation.
And I think it's important to say too that even if you're 60 or 70 or 80, you should still be getting your exams every year and still doing self-examinations, because even though you may not get your menstrual period anymore, or you've had a hysterectomy, or whatever the case may be, you're still at risk.
Absolutely. And one thing to consider is that if a woman has at least 10 years more of life expectancy of good health, then absolutely that still should be a consideration to get a screening mammogram.
Okay. And so I know you've got a little bit of cancer history, a story of you and your wife. Tell us a little bit about that.
Sure. Well, what I was mentioning earlier about radiation therapy to the chest, my wife did have a diagnosis of Hodgkin's disease when she was as a child in her early teens, and she was treated with radiation therapy to the chest. What that does is, over time, again, the radiation risk to the chest, the breast receives that radiation, and that potentially causes an increased risk for breast cancer. There's a debate on how high of a risk that is. I've seen in the literature anywhere from 40 to 50%. So if high risk is considered 20%, we're talking at least double that risk for breast cancer. So I consider that extremely high risk. Okay, so that's why those patients, it's even more critical that they get screening. And so not only those types of high risk patients, like my wife, needs to get a yearly screening mammogram, there are some other screening tools that could be considered as well. In particular, the most important screening tool for those women at very high risk would be a breast MRI.
Okay.
Okay, and so that is it's a higher end tool. It's a more costly test. So that's why the average risk patients will not get that done. Okay. It's saved for the very high risk patients. It's been shown that the MRI will detect very, very small cancers much sooner than a mammogram will even show up sometimes. The problem with MRI, of course, it's the cost. It is more expensive than a mammogram, and also there are a significant number of what we call false positives, meaning something may look like cancer, but it turns out not to be cancer. So it is a very important tool that we have. Not only to screen high-risk women, but also women who have already been diagnosed with breast cancer. Okay. MRI can be done to look and see if there is a small cancer in the other breast, which would affect the woman's treatment of the breast cancer that they currently have. So MRI does have some very good uses, but also we have to keep in mind about the cost. Right. And about the fact that there are false positives that we have to deal with.
And kind of walk us through the process when I go for my mammogram. If I'm still doing the 2D, the regular digital mammograms that we're doing now, if you see something as a radiologist that's suspicious, what would be my next step? Would you do another mammogram? Is that when you go to an ultrasound? How does that work?
So the way it works, a woman comes in for her screening mammogram, gets the 2 pictures of each breast, and then goes back home. Then we as the radiologist, we interpret the exam, and if we see something that looks a little bit different from an old mammogram or something that looks a little concerning, we have what's called a callback. And so we mark the area that looks concerning, and then we have the woman come back for some additional imaging. Most of the time that means we're going to have her come back and do a diagnostic mammogram where we take a couple of additional pictures of the breast, maybe a little bit of a smaller compression. We'll actually compress the breast more than usual for our routine pictures that we take for our screening mammogram. And then if there's something that persists on those pictures, then we may end up doing an ultrasound. Not always, but ultrasound is done a lot as part of the diagnostic workup to see if something is showing up on a mammogram.
Okay. Yeah, and we talked about going with 3D mammography and how great that is taking the pictures, but also reducing those callbacks, right? And the anxiety that a woman goes through when she hears, oh, there's something suspicious, oh my God, do I have cancer? And then, trying to reduce that and knowing specifically with that 3D mammography, seeing a clear picture and knowing for sure what it is.
Absolutely. 3D mammography has been shown to do two things, and this is pretty important when it comes to a diagnostic and a screening test. What you want to try and do is you want to try and increase the detection of true cancers, and you want to try and decrease the amount of false positives. And so what 3D mammogram has been shown to do is to do exactly that. It picks up cancers that we don't necessarily see on our routine 2D screening mammograms. And not only that, but it decreases the number of times that we have to have those callbacks, which I think is so important because those callbacks can lead to a lot of anxiety for women, and I totally understand that. If there's a way that we can decrease that, that would be very, very important. And we have that capability. 3D mammograms have decreased the callback rate between 15 to 20%. And not only that, it's picked up small breast cancers. It increases the detection of those breast cancers by about 20%.
And I experienced that personally. I had a mammogram done, and I had to come back and have a second mammogram done, and then they did an ultrasound, and then I felt really not secure with what results they gave me. Told me everything was fine after that. I didn't believe them, so then I went to another place and got another mammogram because I didn't feel comfortable after going through that many phases. I was like, oh my gosh, what if they're not right? I need to get a second opinion. So that was big for me, and that happened many, many years ago, but I'm very faithful about going every year and having that exam and making sure that everything's good to go. But I know that women do experience that. I had a lot of anxiety. I'm on the phone with my friends and family. Oh my gosh, I have to go back for another mammogram. So I think this is great 3D coming down the road, and I think we're gonna, definitely benefit from that. The women will be happy. I know there's concern that it might be a little more expensive to the patient, but we at Johnston Health are gonna make that our standard of care, so it won't be an additional cost. So we look forward to definitely getting that. Dr. Bizzell, I hear a lot of women say too that cancer is not painful. And then I was reading some things that said, well, in early stages, you may not have any symptoms, and that's why it's important to get our exams. But as it progresses, it could go into other parts of your body, or you could have some pain, that kind of thing.
Absolutely. It is important to know that breast cancer most commonly does not cause pain, as you said. So it is very important to just keep in mind, if you have pain in your breast, but you don't really feel a lump, the chances of that being breast cancer, I would say, is pretty low. So that is something that could be reassuring, but at the same time, if you do have pain, we still recommend that you come in for a mammogram, and not only to get a screening mammogram, but to get a diagnostic mammogram. So some of the indications for a diagnostic mammogram include if you feel a lump, if you have pain, if you have any discharge from the breast, whether it be clear or bloody, any sort of color, those are some indications for a diagnostic mammogram. Of course, another indication is if you have an abnormal screening mammogram, then you come back and come in for the diagnostic mammogram. So having 3D mammography, that decreases our callbacks. So the ones that actually have abnormalities that we see in the breast, there's more of a concern that there could be something there. But I also want to say, if you have a mammogram and you have a callback and you have to come back for a diagnostic mammogram, it does not definitively mean that you have cancer. That's something to really keep mind out for. That it can be concerning, but at the same time, especially women who have dense breasts, even slight differences in positioning in the way that you get your breast positioned in the mammogram year to year, that can make just subtle changes on the mammogram, and so that can trigger what's called a diagnostic mammogram, but at the same time it may just be your normal dense tissue that's just in a little bit of a different position. So that's something to keep in mind, so that if you do get a call back and have to come back for a diagnostic mammogram, it does not definitively mean that you have cancer.
Right. And it's important to work with your doctor, your primary care doctor, and keep them up to date. You know, obviously you're going to send results to them, but also having that collaboration between you, your primary care doctor, and the patient.
Absolutely, and that is very critical. It's more than just getting a mammogram. There's a whole system that's in place for that, and of course it begins with the patient. It begins with you. That you have to be the one to feel your breast and know what your breast tissue feels like routinely, and not just once a year or so. Things can pop up, and it's important to keep that monitored. And it's also important to have a breast exam by a physician or a practitioner that can also have a baseline and have a feel for what your breast feels like. That can be very critical, especially in women who have dense tissue,
right,
or we describe as the fibrocystic disease, women who have lumpy, bumpy tissue. So it's very important to not only have yourself evaluate that, but it's also to have a medical professional evaluate that, and in conjunction with getting a mammogram.
Right.
So all of that together is the best screening that we have right now. So mammography, together with the clinical breast exam, it decreases mortality from breast cancer by 30%. That's absolutely amazing.
Yeah, it really
if you just have a breast exam but you don't get a mammogram, we don't have that same mortality decrease.
Well, and if you have pain or any change that you notice, don't wait till your next mammogram to get that checked out.
Go get it checked out immediately.
Immediately, yeah. Better safe than sorry.
Right.
And you know, as we keep saying, early detection, because the earlier that we can catch it, the earlier that we can diagnose it and take care of it and get you through whatever that may be, a treatment, a removal of the lump, whatever stage it's in at that point.
And the earlier the treatment, or the earlier the detection, the more treatment options there are. There may be, if it's picked up at an advanced stage, then we're talking about potentially chemotherapy, we're talking about radiation therapy, and potentially surgery. Whereas if it's picked up at an early stage, depending on what type of breast cancer that it is, there can be some different treatment options where it may not require having radiation, or it may not require having chemotherapy. So that is very important. The earlier that we pick it up, the more options there are, and the much more treatable it is.
And Dr. Bizzell, I just wanted to touch real quick. There was an announcement yesterday, I believe it was, from the American Cancer Society about the new recommendations for women to have their mammograms. And so I know there's been a lot of uproar about that because women are concerned. I think a lot of people are angry at this change. So let's just talk real quick about that.
Sure.
The the recommendation before a couple days ago was age 40 every year to have that exam.
Right.
And so now their new recommendation.
So the new recommendations, American Cancer Society just came out and said that screening mammography should begin in an average risk woman beginning at the age of 45. And from 45 to 54. So for the first 10 years, get a screening mammogram every year. After that, it goes to a screening mammogram every other year. And there is no defined age as when to stop screening mammogram at this point. Again, it goes back to the lifetime, how many years the woman has expected left to live. If there's at least a 10-year life expectancy, then mammography is still recommended as a screen for those women. Even if a woman is 80 years old, if they're expected to live at least another 10 years, they should still continue to have screening mammogram.
Yeah.
So that is a big change, that they changed that from going from starting at age 40 every year. Now it's age 45. So another thing that they did is they actually took out the recommendation for a yearly clinical breast exam by a medical professional. So I don't know. A lot of people are wondering about that, because that is something that is part of a good screening program, is by getting a yearly screening mammogram plus having a clinical breast exam.
Yeah.
So not having that, I worry that we're not going to be picking up every cancer that we were before. But I would say this, that the American Cancer Society also still said that screening is an individual decision between a woman and her physician and family. They're not saying that you can't get a mammogram beginning at age 40. That's just not part of their new guideline.
Right. And it's important that it's a recommendation. It's not set in stone. Like you said, work with your doctor and, see what's best for you. And, I'm just telling everybody, go every year and get your exam and do your self-exams.
Right. And I would like to say one thing I don't think that they considered when they came out with these new guidelines. They were still looking at our old 2D mammogram screening, and they weren't including our new technology of 3D mammography.
Okay.
Part of their explanation for raising the age to 45 from 40 is that they claim that women within the first 10 years, so between 40 and 50, there's about a 40 to 50% chance of a woman having a false positive mammogram on screening. So that's a pretty significant false positive.
Right.
So that they took that into consideration. But I think what they didn't take into consideration is we have this new technology that's a 3D mammogram that decreases those callback rates, so the false positives will be less than they were otherwise. So I think, again, I think they took what sort of information they had, but just keep in mind that breast cancer screening is still critical and that every woman should have screening done.
Mm-hmm. Great. Well, and I think, again, it's a recommendation, and it's so important that everybody goes and gets their exams, does their self-examinations. And, there's other organizations out there that have different recommendations, so work with your doctor. And we just appreciate everything that you're doing to help women stay healthy.
Well, thank you.
Well, thank you so much for coming on the show today. I think this is such an important topic, and to educate everyone on breast cancer awareness and taking care of yourself and eating healthy as well. So thank you so much, Dr. Bizzell, for coming on the show today.
Thank you for having me.